Good afternoon to the audience who is joining this webinar. Welcome to this webinar, this international webinar with international faculty and Indian top neurosurgeons. I have great pleasure in welcoming you for this webinar, skull-based meningiomas, surgical nuances. This webinar is coming to you through digital initiative of HealthNU Therapeutics, a joint venture with New Link Company Limited, Japan. Today, I have great pleasure in introducing such a well-known personality in neurosurgery, Dr. Dev Pujari sir. He is a leading neurosurgeon of India. He has done fellowship in NGS Newcastle, England, and Henry Ford Hospital, USA. Sir is a visiting faculty in many international universities. For example, Shinshu University, Japan, Emory University, USA, and is also faculty in Indian institutes like SGPGI, Lucknow, AIMS, Delhi. Sir has been speaker on international symposium of world-known bodies like WFNS, ASNS, ACNS, and World Endoscopy Congress. Sir has published many books and contributed to the chapters of textbook of neurosurgery. Sir is past president of NSI, ISPN, ASPN, and skull-based surgery ISNO. Sir is currently chairman of WFNS, Neuroendoscopy and Neuroendocrine Committee. Learning from Sir is a dream come true. Sir has put together today's webinar with international faculty and Indian top faculty, top neurosurgeons of India. Sir, over to you.
Thank you, Deepak, for the kind introduction. I think the stars for today are our speakers. We have the pleasure of having Professor Nanda, who's the chairman and professor at the Rutgers University in New Jersey. And he is secretary of the AANS, the main organization of neurosurgery in the United States. And he's a well-known skull-based vascular neurosurgeon. And it's our pleasure to have him here today, talking to us on anterior skull-based meningiomas. He will be followed by chairman of the university in Prague, Professor Benes, who's going to talk to us on middle fossa meningiomas. And then our own Dr. Atul Goyal will follow with posterior fossa meningiomas. I know it's a very, very wide field. We have recently been covering the skull-based anatomy, and there is a series of meningioma webinars coming up. So I am very fortunate to have the speakers we have for today. We are also fortunate to have a very good panel for discussion, including Dr. Dilip Panikar, who is the chief neurosurgeon at the Aster Hospital in Kochi. We also have Dr. Hemant Bhartiya, the director of neurosurgery at Fortis Hospital in Jaipur, and Dr. Suresh Sakhla, who's a senior neurosurgeon at the Global Hospital in Mumbai. We are also fortunate to have the president-elect of the International Meningioma Society, Professor Suresh Nair, with us. And without wasting too much time, I would request Professor Nanda to talk about his experiences and give us some tips about the surgical nuances of anterior cranial fossa meningiomas. And then I will leave the discussions to the eminent panel for the day. Thank you.
Shekhar, can I also introduce Anil, if you allow me?
Please go ahead.
I will like to introduce Anil as my, we have grown up together. And Anil was with Laligam Shekhar when I joined him. And I have seen his career, I have seen his personal life. And I know Anil has been an achiever. Anil is believe me, Anil is a tremendously respected neurosurgeon in America. I have seen some very top forums in America where he has actually conducted those symposia. And he's honored, he's loved, and he's quite a well-known top neurosurgeon of the world. Anil, I share the pleasure of Dr. Dev Pujari in welcoming you, and I look forward to your presentation. Anil.
Thank you so much. Can you hear me?
Yes, yes.
Yes. Okay. But thank you for this very nice introduction. But there's a good saying in no matter who you are, you pay $2 in the New York subway. So, I think the soul is the same no matter where we are. We can all say our ego is our thing, but I think the one thing the COVID crisis has taught us, a lot of us are over 60 and we're very vulnerable. So, life is all about ayaram gayaram. You can never be sure. So we're very blessed. Thank you so much for having me. I really appreciate it. Trying to move my screen here. Yeah. And I want to thank everybody. I think Vladimir Benish is sort of a great team here. I want to thank Dr. Bhartia, who had the wonderful meeting in Jaipur. It was one of the most beautiful meetings I'd been to. Suresh Sankla, I know from his days when he was a fellow here, so wonderful friendship. Dilip, I'm always personally indebted to. My son got appendicitis when we were visiting Kerala, and he was so good to us. We'll never forget that. And Dr. Dev Pujari is the Bahubali of neurosurgery. He's a wonderful person. And, I look upon him as a brother. So thank you so much for having me, and thank you for organizing this. I think the 800-pound gorilla in every room today across the world, the Sanskrit word for this is pralaya. This is like pralaya has come. It has changed everything. The way we were, you think about it, 6 months ago, if somebody said there'd be 18 million cases across the globe with almost 1 million deaths, you would have laughed at that. That's not going to happen. So I think it's a deeply humbling experience. And I think it's important to remember all those that we've lost. Jim Goodrich, actually, Dr. Bhartia will remember, Goodrich was with us in Jaipur.
Yes.
Alice with him in Jaipur. What a wonderful human being. And unfortunately, we lost him. Dr. Vinaku was the first Indonesian female neurosurgeon in Indonesia. We lost her. So there's been a lot of loss, and I think we should thank God, that we're going to get through this. And with the grace of God, everything will be fine. This was the New Yorker. He said, even if you go up to the pearly gates, they're checking your temperature if you go up. So I can tell you, at least in the US today, everywhere I go, my temperature is checked. Every hospital I go, before I get into the hospital, they check your temperature. So it's a different world, and I just heard right now that the NSI meeting has been postponed. All the AANS was canceled, the CNS has been canceled. We had a global neurosurgery meeting, which is going to go virtual, and I'll talk to you about that. So the world has changed, and we don't know what's going to happen. So I've been very blessed. I spent 27 years in Louisiana, and did about 16 to 18,000 surgeries and about 5,000 craniotomies. So I had a nice experience with skull-based meningiomas. And I go quickly to the anatomy of anterior cranial base. I think the anatomy is very key for the residents on the call, on the conference. I think it's really important to really know anatomy. And I think this is where Rotan was the modern day Galen. He was like Vesalius and Galen for the 20th century in the sense of teaching us anatomy and reminding us how important it is. And here you can see beautifully the anterior cranial fossa, all showing really well. And I like to show this side because it's important to remember the ethmoidals come here from the base. And I always come from one side. I have a one-sided bias. And I think it's important to know the vascular supply. I don't embolize a lot of these vessels, but I think it's important to remember that you're going to come across them and you want to attack them early. So again, to look at all the anterior cranial fossa meningiomas, I think you should know where the frontal sinus is, the cribriform plate. And I think when I started, I was very aggressive at drilling out bone. I'd do bicoronals and extended frontals and take the orbital roof off. And then, age has a wonderful way of maturing you. And you're like, maybe we don't need to be that aggressive. It's just like petroclival meningiomas. I used to do petrosectomies all the time. And you sort of move away and say, maybe the old tools are the best. So sometimes it's good to have that bias. I just thought I'd share a little bit of history. of anterior cranial fossa meningiomas. You can see here, this is a very common sort of tumor, but was described by Cushing. And then, the Foster Kennedy syndrome was described in 1911. And then in 1879, William McEwen, he took out a 14-year-old's meningioma. But I think the giant for skull-based meningioma was Durante. He actually took only an hour to take out this large tumor. He was from Sapienza University in Rome, and he published this in the Lancet. And probably the first neurosurgeon to take out a cranial-based meningioma. He became quite a legendary person in Italy. But I think he almost looks like Rajneesh there. Acharya Rajneesh used to have a long beard like that. So maybe Tagore, not Rajneesh. So I like that picture. But then you look at, Cushing. Cushing obviously comes up with the word meningioma. But here you see how he would sort of has this beautiful technique of devascularizing the tumor and then removing it. And of course, this is his landmark book with Louise Eisenhardt, who was actually the first female president of the Harvey Cushing Society, which is the AANS. So my series of anterior-based meningiomas, are about 180 of these. As we know, most of these are female, and they can be from 3 to 10 centimeters. Some of these are large. And with skull-based approaches, you can say, oh, we'll take this off, we'll take that off. But when you have a tumor this big, once you internally decompress them, you get so much space. So, I just for the younger people in the audience, don't get moved away. I got to get much more exposure. With a tumor this big, when you debulk it, you'll get a lot of space. So I always feel that's a good way to go. Here's somebody who was institutionalized with a 9-centimeter meningioma. Nobody got a CAT scan. 6 months later, she got a CAT scan. We removed this. She actually went back to being with her husband and living with him. And here's another one like this. So I have a one-sided bias. I do not like to touch the contralateral frontal lobe. I got burnt when I was younger. I had some outcomes which psychologically were not that great. So after that, I moved away from that. And you can see here, this tumor, you could argue should only be done through a bifrontal. But what I did here was, you see the falx here? I divided the falx and then pulled everything out. So I went completely unilateral. And here's the view. I put some glue there at the base of the skull. And you can see he lost a lot of weight. And he's actually followed up now for 10 years with no issues at all. Side tumors like that. So basically, I've gone terional, orbitofrontal, but bifrontal, I kind of moved away from completely. So this is after I moved up to New Jersey. This is somebody that had a lot of cognitive skill set problems. And here you can see she got divorced. She was really apathetic, would not talk much. So in this case, I came from the left, and because this tumor is large, I devascularized the base from the bottom, but then I made a corticectomy in the top. And from that corticectomy, I debulked all this part and then came from the side and got the rest of it out. And she's actually done beautifully. She's back cognitively now. I've had her over a year follow-up, no recurrence. The other thing is, the meningioma grading system was revised 10 years ago. And so we used to see grade 2 was just like 10% of cases. Now we're seeing it 30% of the cases. The problem with this is radiation therapists have a very itchy trigger to radiate. So they're like, oh, grade 2, giant meningioma, you got to radiate. So they really wanted to gradate this grade 2. But, I'm still a little hesitant. And I'll talk about, I will sometimes gamma knife residual, but I don't like to go with radiation. I just feel that you may not be able to come back and there'll be more issues. So here's another one, grade 2, that I've done here in New Jersey. You can see the nice outcome, a lot of edema. But again, grade 2, we're not having radiate, I watched them. And some of these are fibrous. This is, again, an older lady, 80-year-old lady with cognitive deficits. We moved very quickly on this case. We did this like in an hour and a half. And I think this was soft, so the CUSA really works. And I think that makes a big difference with a good resection there. Same thing with hemangiopericytoma. These are really vascular. but we stay on the plane, and I think it works really well. I will say a few words on the extended frontal. I worked with Dr. Shaker and Dr. Janetta. In fact, Atul was with me at that time in Pittsburgh. It was a magical time. And we published this paper, the extended frontal. And it's a great paper, and it has a nice citation to it too. But guess what? I rarely use this. I've used it for extradural things. I really don't use it for meningiomas or even clivus tumors. So tumors like this, I always go to the side. I go from the side. If it's larger on one side, I'll go on that side. Devascularize the base, so you can see here. Let me just play this. So we devascularize the base, and I'll sometimes use loops. So I really do a lot of my stuff with loops. You know, I can tell you for routine aneurysms, I split the fissure with loops. And so I do a lot of my work with loops, and so here we're going down to the base. I like to devascularize the base. People say, oh, you have to be very careful. No, I don't use micro bipolars here. I use the big bipolars. I put the bipolar up to 45 or 40. And sometimes if you have really troublesome bleeders on the base, I will actually use the bovie itself, because the ethmoidals can really bleed. It's very irritating. It can be very vascular. So then I try to sort of remove that. But again, I devascularize the base. If you devascularize the base and you can see the other anterior cranial fossa from one side, and then you come posteriorly to right up to the tuberculum sellae, if you're free on all that, then it's almost like a convexity meningioma. So you can see here, these are some nasty bleeders, and I really like to bipolar those in a solid way. Here you can see now, you can see you're off, and posteriorly you can see we're free from that side. You want to stay in that plane. And if you're taking a petroclival meningioma, the brainstem, your bipolars are very fine. You have to keep the heat really low. But this part is like nasal surgery. So I think when you come down on the bottom there, I'm pretty ruthless with heat. You know what I mean? I'm like, no, you can go fast here. You don't have to be that, once you devasculate. Now this part, I'm taking it off the frontal lobe, obviously worry about the anterior cerebrals. And I'll touch upon vascular injury. Many times these large meningiomas are very adherent to the anterior cerebral, and you will get minor bleeders or even sometimes a small hole in the anterior cerebral, and I just bipolar it and then maybe put some papaverine on it. But that's the big thing with these cases. Again, CUSAs have saved hours on these resections. So a lot of heat. This is not sensitive type surgery. I think you have to be sort of firm and move along pretty quickly. So you can see nice plane, just like that. You're in the arachnoid plane there. And the thing is, this is what I like to emphasize. Once you debulk and you take tumor out, it creates space for itself. So it actually goes much better. Here we're actually taking it off the frontal lobe. You can see the post-op. Another one like that. These are a different kind of bipolar that I use. But I think this is the single most important maneuver on these cases, yeah. Sometimes the brain really swells up and I'll just go open the cisterns, take some fluid out. But here the base has been devascularized. Sometimes the CUSA is not good enough for this. They're too firm. And here we can see we're taking that out, devascularizing it. Just basic sort of meningioma surgery. And here you can see the results there. But so large tumors, I only go from one side. So you can see here, we went from the right and we're easily able to get that out. Here's someone I did recently, 50-year-old with visual loss. So when they have visual loss, you want to be very careful with the chiasm because obviously it's going up a little bit more. So then we looked at the extent of frontal lobe damage, because obviously I had a one-sided bias. And I'm like, what happens to the changes in the frontal lobes? The only way we didn't do the best test, obviously, is neuropsychological testing on these patients. So you need pre-op and post-op. And you can see here, we actually looked at the changes. These were our series. We looked at pre-op KPS, follow-up headache, anosmia, mental change, visual impairment. And what we found was, if you look at the ratio of the parencephalic cave to tumor, it was statistically significant. So if you want to look at here, we looked at the bifrontal approach and the right side approach, and you can see there wasn't that much change. So when we looked at 57 patients that we had done this on, that the lateral approach resulted in less frontal lobe damage than the anterior approach. And this was sort of repeated by Tomasello's group in Italy as well. What about tuberculum sellae meningiomas and diaphragm sellae meningiomas? We published our series on this. And if you look at the history of these, Holmes and Sargent first described the chiasmal syndrome, which is optic atrophy with bitemporal field defects. And then Cushing and Eisenhardt talked about it. And then, of course, there's been a classification by Kinjo from the upper leaf and the inferior leaf, yeah. So we looked at our series, and, you know, small, moderate, and large. And I must really acknowledge a lot of the fellows, a lot of the NIMHANS fellows have worked with me over the years and helped me put a lot of these papers together. So I'm always grateful to them. So you can see this is just the pre-optic, sort of the optic nerve, how it's draped over. And so with these smaller tumors, and I think, you know, at this day and age, a lot of people say, well, this should really come out through a trained endoscopic approach. And I have had really good results technically with this. So you can see this was something that we removed. And we showed our results with optic canal involvement and visual loss. And we'll talk about visual loss. So something like this, which is clinoidal, which goes out laterally, you cannot take out endoscopically. And here you can see we have split the fissure and we're going down, skeletalizing the base. The thing that I like to emphasize, I really don't like to touch the optic nerve. So I can put a lot of heat on anterior canal face-based meningiomas, but on something like this, when you're near the optic nerve, then I completely become very careful, fine instruments, no touching of the nerve itself. In the interest of time, I will, sorry, I didn't do that. But what I just wanted to show was here, at the end, we're just peeling this off the optic nerve. You can see the internal carotid artery, anterior cerebral, and here's the optic nerve right there, completely untouched. So we did not touch that at all. So endoscopic has been an amazing advance. I do chordomas. I do a couple of cases that way. But, you know, how do we adjust to new technology? And so if you look at a meta-analysis of sublabial transsphenoidal, it has been the gold standard. But if you look at the CSF leak rates and endoscopic visual loss, this was a meta-analysis that was done. And this was done a couple of years ago. So the results are obviously better now. And if you compare quality of life, actually they do better. But I think there's issues like this one. This was a chordoma that I felt we had a better section. So to wrap up, I know my time's coming up. I just think we published our grade. I think Simpson grading is still very important for these tumors. The UCSF group didn't think so. And this is our total number of meningiomas that we looked at. Skull base was 381. I think complications is something we all need to talk about. I will say I've had visual deterioration in 4 cases that I had 10% visual deterioration. Sometimes you take a little vessel, you can have visual loss. CSF rhinorrhea, I had 3 cases, 1 required a craniotomy, still much lower than endoscopic. So I think endoscopic is a great advance. It's safe, effective. And I think all skull-based meningiomas, we've come a long way with good outcomes. But I think we need to be very honest with outcomes. You know, we shouldn't say, "Oh, everybody does great." I will end with Franco Sarvadea. he talked about, he was in the middle of the Wuhan virus. He says, when the virus spread through China, people said it was because of Wuhan. When it spread through Italy, they said, oh, everybody's old. And when it went through Spain, it was because of the healthcare system. And I'm kind of reminded about Niemöller, the Lutheran minister. He said, first they came for the socialists, and I didn't speak out because I was a socialist. Then they came for the trade unionists. Then they came for the Jews. And then they came for me, and there was no one left to speak for me. So I think we need to be vigilant on this virus. On a more positive note, I want to invite all of you for Global Neurosurgery. This is going to be a virtual symposium. It's free. I would encourage the residents to come. We have multiple sessions. We have panelists, and we have sort of exhibit halls, virtual exhibit halls. So I'd like all of you to come. And Sir Michael Marmot is going to give the landmark speech. He's a knighted physician from England who will speak on healthcare inequalities, and it's the first Peter Carmel oration. So I'll end with this rainbow. The rainbow is a symbol of divinity. And at the height of the crisis, the coronavirus, when we were all losing hope and thousands of people were dying, this rainbow appeared. And it was a sign to me that all will be well. And so we got to the other side. And I hope this rainbow comes to all the epicenters in India, all over the world, so that we can meet in person again and enjoy each other's company. So because everything that divides the human spirit unites us. So thank you so much for this opportunity. As you realize, I grew up in Bombay, and I feel like I'm with my brothers and sisters there. And congratulations on everything you do. And thank you again for having me. I really appreciate it. Hi, Vladimir. Good to see you.
Welcome, Dr. Benes. And Anil, that was a great overview. And you already talked about your one-sided bias. I thought it only meant transcranial, but you really mean unifrontal or perional. There are two questions which have come from the audience. I'll put that to you as well as to rest of the panel. One is, do you see any role of pre-operative embolization for anterior skull meningioma?
So I can tell you, I really have a bias against, even with AVMs, I really don't use embolization much. My feeling is I'm there, I'll catch the ethmoidals, it shouldn't be a big deal, So I stay away from embolization. I know my colleagues love it. I tend to say, keep it simple. I have control, I'm going to be better off. So that's why I kind of prefer not to do it. But sometimes if it's really horrendous or something, or it looks really vascular, then I'll definitely do it.
Dr. Benes, do you have any opinion on this?
Well, when we started with endovascular, we started with meningiomas as well, not many. And there was one lady, she was 90 or past 90, and she had a sphenoid wing meningioma, and she was deteriorating, and she was definitely poor surgical candidate. So we embolized the tumor, and the lady survived for another 3 years, and the meningioma decreased in size considerably. Oh. But to be perfectly honest, that was the only case when we were so successful. And recently we don't do it.
And as a pre-operative embolization to reduce the vascularity?
Pre-operative, you mean?
Yeah.
Pre-op. Very rarely, once in a year probably. And I don't really think it helps much, because meningioma surgery is about attacking the orgo at first. So you devascularize the tumor as well. It's very similar to AVM when they embolize the big feeders. You find them easily yourself. You need the small feeders. And this is something which is impossible. So, no.
Anyone in the panel would like to comment? Dilip?
No, I think this whole thing about embolization of skull-based meningiomas keeps coming up at every forum where these are discussed. I think there are some very strong proponents who very actively suggest that skull-based meningioma should be embolized. But I mean, I have personally never embolized any skull-based meningioma. And if you follow the right technique, and it's a very systematic technique, go to the base, devascularize the tumor, debulk, go to the periphery and excise. It's a very systematic step-by-step process. And that makes it actually very straightforward in the majority of cases. So I really don't think this whole thing about embolizing a meningioma is going to give us any further advantage. On the other hand, we have actually seen a tumor. In fact, this has happened to me on 2 occasions where you very aggressively go and devascularize the tumor extradurally. This has once happened to an olfactory groove and another to a sphenoid wing, where you very aggressively go and devascularize these tumors. The tumor necroses. And suddenly you find as you take the supply extradurally, the whole tumor swells up, your brain swells up, and you very quickly open the dura, your tumor is mush. It's become necrotic, completely necrotic, and that's a change that has happened suddenly. So you can imagine what would happen if you embolize the tumor and this happens to your tumor. You'll be rushing from the lab straight into the theater in a fairly unprepared patient. I don't think it's a very wise idea.
Suresh, any comments?
So
Dr.
my
Nair and Dr. Sankla.
I agree with Dilip and everyone else. You know, the embolization, the role of embolization has been very, very limited nowadays with the kind of technique we are using, the skull-based approaches, where you can easily, you know, coagulate the base and devascularize the tumor right from the beginning. And that makes all the difference. I don't know if Dr. Nanda has any case or any situation where he uses embolization nowadays, if he's around.
He says no.
He's
Just,
okay.
Nair, do you have any comment?
The hemangiopericytoma, they are the ones which will require embolization, not for other meningioma.
Dr. Sankla will remember, we both worked with Dr. Bhagwati once, and we almost consecutive, I think 90 meningiomas were embolized, all kinds. And one of the things which we found, he actually wrote up about this. One of the things which we also find is that apart from the fact that you can probably take the ethmoidal and occasionally some supply from internal maxillary, there is not very much you can take, and especially many of these are supplied by the ophthalmic artery as well as the anterior falcine artery. So sometimes it can be tricky to do that. The second question, Dr. Nanda, is do you have? I mean, this is my way of understanding the question. When you are doing a meningioma, say tuberculum cellae or diaphragma cellae, you are all right to come from the side, from the sylvian fissure. But if it is an olfactory groove meningioma going right up to the frontal sinus, does it still work for you, or are there any circumstances where you would still do a bifrontal?
I haven't done a bifrontal, I think, in like 20 years. Yeah. You know, I just don't go bifrontal. I think it can be done from one side. I think that's the way to go. But it's a personal bias, you know, and some, you know how we are surgeons are very superstitious animals. And if we get used to one thing and we like it, then, you know, it's like, that's what we use. Sometimes, you know, maybe I'm at fault. Sometimes maybe I should be going bifrontal, but I just feel that that's worked very well for me. And I haven't done a bifrontal in decades. Yeah.
Is Atul with us?
Can I ask a question to Dr. Anil? Oh,
Yeah, Shekhar,
You have any comment on bifrontal?
bifrontal, as Anil said, he has not done for 20 years. I think at least for 10 years, I have not done bifrontal, or maybe more, or maybe 15 years. Bifrontal is not required. Even in massive olfactory groove meningiomas, you can get the whole thing from one side. As you debulk the tumor, you go on getting space. The bottom line is to learn the art of breaking these tumors, to learn the art of demolishing these tumors. rather than, looking for space. Once such a big tumor, what space you want? You see, it will automatically give you space. So there is actually no need for a bifrontal.
Excellent. Dr.
Can
Bennett, you
I-
feel the same way?
Yeah, I would like to add one thing. Anil said that he's coming from the side where the tumor is larger. This is for me for olfactory groove meningiomas and for plano meningiomas. But for tuberculum cell meningiomas, I always go from the opposite side, because the most difficult part of the work in tuberculum meningioma is underneath the ipsilateral optic nerve. And if you come from the opposite side, then you are in direct line of vision underneath the nerve. So this is inverse relation and inverse approach, but of course unilateral only.
Okay. Suresh, you had something to say?
Yeah, I just wanted to make a comment on Dr. Nanda's presentation. Excellent presentation, Dr. Nanda. I was always impressed with your technique of skull-based tumors. Today, you said that you go to the base, you devascularize the tumor, and sometimes, in some cases, which are large tumors, you do the cortisectomy and then do the decompression of the tumor. Can you just elaborate on that if it is really necessary?
No, that was a rare case where it went into the ventricle. It was that large. So that's, it was the only case I've done that on. So no, I normally would go straight to the base. This one was, it was 9/7. It came up too much on that side. So that was the one time I said, listen, let me make a small cortisectomy and debulk that part. It was actually my first skull-based case in New Jersey. I just got here. I was like, okay.
You know what? Should I make a comment on that, Anil?
Yes.
You see, in large olfactory groove meningiomas, and if you are coming from the frontal, I don't like lateral, I like basal frontal. So instead of lateral, I like basal frontal. And you know what? In large meningiomas, if you do a little bit of a cortisectomy of the frontal brain, the whole tumor comes in right in front of your face. And I don't see any harm in doing a little bit of a cortisectomy if it comes to. Believe me, just you come, rather than retracting a swollen brain, tense brain, you just little bit make a basal frontal cortisectomy, get onto the tumor, get onto the job of debulking. No harm in doing a cortisectomy at all, believe me. And I almost do it in large tumors always routinely.
Dr. Turel also recommends that sometimes the last question is from the current chairman of NIMHANS, with whom you have a close collaboration, Anil. He again goes back to the question of embolization. He feels that you can change the consistency of the tumor and make it more amenable. Does that make any
I don't have that much experience because I'm sort of intuitively against embolization, but I do use it for AVMs. I think for deep feeders of large AVMs, I work with Sidri Chowdhury, who's a really good endovascular guy in New Jersey. And deep feeders of AVMs, I like them because I like to see the onyx. It almost gives me a roadmap to take the AVM out. But for meningioma, I have, and maybe I'm making a mistake. It is something to consider. Wisdom is an evolving thing, so you never know.
Hemant, do you have any comment, or should we go for the next lecture?
A little small comment about this embolization. What I feel is that with the consensus of not much of use, but I think this mainly depends on the availability of the facility, if it is available with you. Different geographical means the availability. In the states, it is, of course, in India also now with the intervention growing up. Maybe in coming future, you may have a different perspective of this embolization, although it is not of much use. Second point about the bifrontal, as we also, when we were trainee, we were taught about that doing a bifrontal craniotomy for olfactory groove meningioma and removing even the orbital rim also, so that you have a approach. But then you burn, as Dr. Nanda said, your fingers, and the lateral approach seems to be the best one. And what Dr. Atul said, that you can remove a little bit of cortisectomy, you can do. And instead of that, we feel that maybe more towards stereonal side, you can release CSF and you can get away without doing a cortex.
Yeah, Dwarkanath is again commenting that you can add orbital, remove the orbital sort of rim to get to there better. In fact, my personal experience is first 10 cases I did extended frontal approach in every anterior cranial fossa meningioma, especially something like olfactory groove. And I have now shifted completely to terional myself, unless I can do it endoscopic, but that's not the topic we are discussing now. So I think we'll move on to the next talk by Professor Benes. Anil, will you be able to stay with us for rest of the program? Sorry, we have lost your voice.
Sir, please.
No, I'll be there for part of it, but we are doing telemedicine, so I have some clinic patients lined up. Yeah.
Okay, as long as possible, we'll be very happy with that. Thanks.
Suresh, do you see my screen?
Yes, sir, we can
Yes.
see your screen. Yes, sir.
Okay.
I already introduced you, Dr. Benes. So you have also been a president of the International Meningioma Society. That's one thing I forgot to mention, which I had a pleasure to attend last time in Prague. Please go ahead.
Thank you. It's a great pleasure to be on this audience, and it's a great honor, and especially to be squeezed between Anil and Atul is somewhat difficult, but I shall do my best. My pedigree is from the WFNS Neuroanatomy Committee. So talking about the middle cranial fossa meningiomas, I must start with some little anatomy. Not much, just a little. Middle cranial fossa is composed of two bones, sphenoid and temporal bone. It's petrous and it's squamous part. And arbitrarily, even the sella turcica is part of the middle cranial fossa. But what we do all and what we think probably is the best division is that the line between the anterior and posterior crinoid and petrous apex is the border of the middle cranial fossa. Just underneath the bone is obviously the dura, and in middle fossa, the dura is very, very convenient for us because we have this periosteal dura on the anterior clinoid process. Then we have the dura propria of the temporal lobe, and then we have cavernous sinus with its own layer of dura. And it's rather easy to divide these two, which allows to get to almost all the middle temporal fossa by extradural approach, which is, for instance, in Cavades approach, in all cavernous sinus surgery, we are getting there extradural, and we can reach all these structures which are actually all located in the middle cranial fossa, from GSPN, V3, V2, V1, sixth nerve, fourth nerve, third nerve, and obviously carotid artery. All this can be reached via extradural route and decide where to enter the cavernous sinus should it be necessary. And I might add at the very beginning that in meningioma surgery, I do not see any reason to enter the cavernous sinus. Just below the dura, we have arachnoid, which is probably the most important structure for meningioma surgery. And my big friend Imad Kanan calls arachnoid surgeon's friend. And it's really friendly because that is the layer we are looking for. And we just, unlike in vascular surgery, where we penetrate the arachnoid, in meningioma surgery, we try to stay outside and lift the arachnoid, dissect the arachnoid from the tumor, and this allows to cover the vessels which are in danger during our endeavors. And there are two most important systems. Here we have the optic nerve, we have the cell, this is the carotid system, and this is interpeduncular system. And you see that in carotid system, there is carotid artery, in the interpeduncular, there is basilar artery, posterior cerebral, superior cerebral, and in between them, the most stable anatomical relation of the third nerve. Both these systems as well are the main source of CSF to achieve the desired brain relaxation. Here we see that the third nerve has its own arachnoid, which is much better seen here. And there is even a little system of the third nerve, which may be used for a bit of mobilization of these structures that we are in innerving meningiomas, anterior meningiomas. What's important and what's probably somewhat not surprising, but what's important to note is that all these structures are very close by. This is the carotid posterior communicating, which is penetrating the ligaments membrane to join these two. The CN3 with its own arachnoid. There is the crural system very close by, it's anterior choroidal, and immediately posterior is the ambient system. We are going to the middle fossa. Why did I dwell on arachnoid that much? These are not the middle cranial fossa, but anterior cranial, similar as Anil has shown. And see these two olfactory group meningioma, they are exactly the same size, exactly the same location. What's important that the edema in this case is unilateral and anterior cerebral arteries moved to the opposite side. In this case, the edema is bilateral and the anterior cerebral arteries are in midline. This means that on the left side of this case, the frontal lobe is covered by the three layers of arachnoid because they are dragged there by the anterior cerebral arteries. So much safer resection on this side. In this case, both controls are covered by one single layer of arachnoid only, and more likely maybe injured on the both sides of consequences. This is what can be seen by one single approach. Sterional is the rest of the meningioma within the cavernous sinus, and in this case, the arachnoid was dissected free. I did this case many years ago, but I like this image, and you see almost everything which is on the skull base and in the middle fossa in particular, which is internal carotid, middle cerebral, anterior choroidal, posterior communicating P1 on the opposite side, P2 on the opposite side, the third nerve on the opposite side, ipsilateral third nerve, basilar artery. So everything can be encountered at once, and that is why I consider vascular surgery or aneurysm surgery much easier, because the structures are not moved. Everything is as it is in the textbooks. And this all can be dissected from one single approach. Concerning the meningiomas of posterior fossa, the important structures are, of course, the sinuses, because the meningiomas tend to grow along the sinuses where the density of capsules is higher. And the middle fossa is perfectly delineated by sphenoparietal sinus, cavernous sinus, and superior petrosal sinus, making a big open V or U, whatever you may call it. And it's exactly the border of the middle cranial fossa. On axial, it's like open V, very widely open V is the middle fossa. On the coronal section, you see that it's very concave. And this is something one should realize, because should you need to get subfront temporally to tentorial edge region, say for basilar trip aneurysm or for tentorial edge meningioma, the craniotomy must be positioned very low, flush with the floor of the middle fossa to avoid the retraction of the temporal lobe, which we all have seen these retraction injuries to the temporal lobe. The next danger in these approaches is the vein of Labe, which is posteriorly, and the venous infarction is a dangerous thing. Basically, there are 4 approaches to the middle cranial fossa. Of course, 95% probably, or even more, is the anterior approach, and all its imaginable variation. It means from anterior, and you may reach as far as Gesserian ganglion and all these structures. The subtemporal, which is like middle or medium approach. Petrosal approaches, which are more or less targeted on petrofiber areas, so it's not in the middle fossa. I don't think it would be just for that, and I'm avoiding these approaches because I think that the approach shouldn't be more than the surgery itself. And the last approach is from posterior, when you go above the cerebellum cup, the anterior, and you can reach easily all the medial parts of the middle cranial fossa. Of course, the middle cranial fossa meningiomas are dominated by sphenoid ring meningiomas, which are by far the most frequent meningiomas for the longest these. Yes, someone
can be slightly away from the mic, then it will be clearer, sir. Away.
Away from the mic or to the mic?
Away from the mic, sir. Then it is more clear.
Away. Okay, so I'm sorry.
Yeah.
Okay, in sphenoid ring meningiomas, always anterior part of the middle fossa is affected by the tumor, and the more frequently, the more volume of the tumor is located in the middle fossa than in the anterior fossa, because the origin of the tumor, apart from cranial process, is usually posterior aspect of sphenoid ring. Of course, anterior approach is the working course of this, and in my department, I just asked the resident to perform pteriodontal with either frontal or temporal deviation, whatever is needed, and everyone understands that. And of course, the important maneuver is extraocular resection of anterior cranial process, because this gives an ample space for almost any lesion in the cranial fossa. Quite frequently, these meningiomas affect more compartments like orbit or petroclive region, and we shall come to that later. This is a typical outer wing meningioma. See that there is a considerable edema in this tumor, and if you would check your own patients, you would realize that quite rarely edema is in the front, even if the tumor is symmetric in both compartments. But almost always the edema is in the temporal lobe. That means that the plane of resection between the temporal lobe and the tumor will be much more difficult than in the frontal part. This is another one. You see that it fills the middle fossa both from AP view and from coronal section. Another one, again, edema over here. This is already inner wing where the crinoid process region is affected, and when all the big major vessels are located. There are quite a few of partial resections only, and the same as Anil, the older I am, the less aggressive I am, and although the older the patient is, the less aggressive I am. But even in a young patient, such a tumor will hardly be resected entirely because there is no arachnoid link to the carotid artery. So part of the tumor must be left behind, because it's not only carotid artery, it's also A1 and M1 with all its perforators being within the tumor. So this is the remnant, and this is just okay, because we shouldn't forget very good treatment with the radiosurgery, which usually controls around 90% of meningiomas. This group are sphenoorbital or unplugged meningiomas, which is also drilling and opening the optic canal, and they usually have only very small part of the tumor in the middle fossa, almost never in frontal lobe, but in the middle fossa there always is a part of the tumor which must be resected. So drilling and resection of dura with all necessary dura plus plaste after surgery. Another distinct region is cavernous sinus. If the cavernous sinus only is affected, then the tumors are very typical in appearance, because they are held by dura in this triangular shape. But they are very variable once they get out of the cavernous sinus. We shall see this at the end of the lecture. Various compartments, of course. In my hands, only extra cavernous part is resected. I never ever enter cavernous sinus for meningioma, because I don't think that double vision for the patient is a good outcome. So the reason to operate on cavernous sinus tumors is to decompress the optic apparatus, like in this case, or tailor it for radiosurgery. I know that few people are putting a piece of fat between the optic pathway and the tumor to enhance the possibility of radiosurgical treatment. This is the tumor which penetrated from cavernous sinus into the middle fossa. And you see that only the middle fossa part of the tumor was resected, and this was left behind. And you may either use radiosurgery or observation, which is a legitimate policy by all means. Going a little backwards, just behind the cavernous sinus is the Meckel's cave, where all the meningiomas may appear, but rather infrequently. They may even penetrate into the middle fossa. These tumors, unlike the cavernous sinus, may be resected entirely, like in this case, and it's not really that difficult. And now going a little upwards, we have the tentorial edge and the clinopetros ligament where the tumors may arise. These are again attacked via pterional approach, at least what I'm doing, and they are distinct that the middle cerebral artery is pushed not backwards or upwards, but forwards, which is somewhat difficult because all the perforators there are directly split on the surface of the tumor. But again, from pterional approach, such a tumor is accessible. Quite rare are pure middle fossa meningioma, which are located on the floor of the middle fossa. These, of course, are attacked via temporal craniotomy, which be positioned really low. And if you position the craniotomy quite low, no retraction, no nothing, you are directly on the tumor, and you see that tumor visually is on the surface. Another one being a little higher, one was access not via the temporal approach, but via the exterior approach, and just splitting the second feature to get enough space, because the top of the middle fossa is rather small and triangular, and one may be surprised how close it is from anterior clinoid to the petrous apex. Then there are tumors which are in the middle fossa but are originating in the posterior clinoid region. You see the ligaments, the anterior clinoid petrous, posterior clinoid petrous, and the tumor is in petroclival region in middle fossa. Again, this may be done via pterional approach, and I do it via pterional approach, but these are really difficult tumors with all the troubles with the third nerve and little arteries. It's usually about the craniotomy. Here's the third nerve, about the carotid artery, the clinoid process is resected, and then you get along the tentorial edge, posteriorly resecting the tumor from the floor of the middle fossa, then getting the piece which is below the tentorium, the petroclival part in a way, and at the end, this is the part which was hidden to make up the tentorium, of course, posterior to the entry of the fossa to get space to this area when needed. And after the resection of the main bulk of the tumor, supratentorial instrument for these tumors, you get into the ambient cistern, and you see the posterior cerebral artery and superior cerebral artery, which are directly here at the bottom of the cavity. That's it. For the sake of time, I will go forward. We are getting to the last approach, which is supracerebral. This is sinus. This is the urotomy. Am I muted by the host? Unmuted, okay. Sinus, this is the urotomy, which shouldn't be too low because otherwise the cerebral hemisphere prolapses. And this is the tumor which we did last week, where this approach, you see that it was as low as meatus. Here it's in the middle fossa, quite a big compartment of the tumor, and of course in the petroclival region. Naturally, the origin of this tumor was in the cavernous sinus, so it's sphenopetroclival meningioma, and it's
Sir, we have lost your audio. Sir? We have lost your audio.
Do you hear me now?
Yeah, now we can hear you. Yes.
You didn't hear me for how long? Because there appears you are muted, unmuted.
For 5 seconds. 5 seconds we did not hear you.
So you missed nothing virtually.
Okay. Now we can hear
Okay.
you. Yeah.
Good. So this is the humor. This is the posterior part of the humor in the posterior fossa. You just decompress it, then we get medially to see the. I can't fast forward it to see the middle fossa, which is important in this case. You must have the tentorium, obviously. In this case, you can divide the superior petrosal sinus because it's full of the humor. Here is the mesencephalon. This is the superior cerebral artery. Always the nuisance in this case is the fourth nerve, but fortunately, even the loss of the fourth nerve is the least injury you may cause. So this is the mass of the tumor, and now we are getting supratentorially into the middle fossa, and we should. That's it. That's already part of in the middle fossa, and we go as forward as the third nerve, optic chiasm. No, we are now low. This is the seventh, eighth, resecting still higher and higher. You can get as far anteriorly as the third nerve at the optic chiasm and pituitary stalk. You get the opposite side structures as well, both salivary processes. We are already in the middle fossa. This is the part of the tumor which is hidden below the tentorium, so the tentorium must be cut. And here it was quite difficult to achieve the plane of dissection between the wall of the cavernous sinus and the middle cranial fossa, since the line of sight was perpendicular. This is the third nerve already. And then at the end, you get medially to see the sixth nerve, which is and maybe stimulated us to make sure. And of course, the fifth nerve was in this case completely embedded in the tumor. So this is the third nerve, this is the uncus, and here we are getting the rest of the tumor lying on the cavernous sinus. This is after you see that the piece of the tumor was left in the cavernous sinus, but the piece of the tumor in the temporal middle fossa is resected by this approach from posterior. So let's go to taxonomy, which is in my mind the most difficult part of these tumors. This is orbitosphenopetroclivar tumor. It's in orbit, it's in petroclivar region, it's in cavernous sinus, it's in middle fossa. How to define this? This is difficult. My hobby is entomology, and I'm collecting beetles. This one is from Mexico and is very distinct and very well-defined species. Chrysina beneshi is described in my name since I collected it. Here is the other one which I have collected in China in high mountains. And at first it was described as Ecoptorabus beneshi again, sorry for that. But then someone compared the other similar specimen, and you see that these are completely different, but they have the morphological signs same. They have the same penis, penis. You see that it's really big considering. And ultimately, this ended up, and what's now used is in entomology is group exiguus. The name is Ecoptorabus exiguus. This is what is acknowledged by the zoological societies, but there is a group of similar beetles. And you see that if only genus and species is acknowledged, let's say genus Sphenoid wing, species lateral, middle, medial, then we need to go a little lower into the unacknowledged parts, like subspecies, aberration, form, variation. And there may be clinoidal, sphenoorbital, whatever, medial anterior clinoid, lateral anterior clinoid, both different species, but the same species. We could have something like a key. You go from one paragraph to the other. If it's right, then you go to the next. If it's not right, you are directed to another part of the key. And we can be defining the tumors like that. How would you define any of the faculties? Is it cavernous sinus? probably the origin in cavernous sinus, but it's in the orbit, it's on the plenum, it's in the sphenoid cavity, it's in the middle fossa, in all these compartments. And if you take all the meningiomas which we are dealing with, there is the only blind area, which is the spinal canal. And then there are transition zones, and you can go all around the skull, just going from one tumor to the other, which will be like overlapping. See these in the Petros ridge, CP angle, then we are going to petroclival region more and more. And if we get a little forward, we get to the cavernous sinus, which probably is the mother of all. So probably something like that could be constructed, something like a key for meningiomas. What about the results? I'm always a bit hesitant when I listen to a series of petroclival meningiomas and there is no mortality and almost negligible morbidity. In my end, this is not true. We were mothers in sphenoid ring in 280 cases. We had 1% mortality and another 4% serious morbidity. So altogether it's 5%. And I think that in all skull-based tumors, this is almost unavoidable because there are vascular injuries which you inflict even with the best of hands, impossible. And then there is the problem of patients which are too much too late. They come with a huge tumor, they are 85, they have Glasgow, 7. It's really difficult to expect a good result in such a case, but it's almost impossible to refuse surgery. And somehow I have the feeling that these patients are not in all statistics I'm listening to. To conclude, management, diagnose the tumor, of course, easy, MR. Draft the anatomy, think about the anatomical relations before the hand. Really spend more time with the MR images than in surgeries itself. Decide the approach. The proper approach is paramount. In middle fossa, it's really pteriodal, which is always the best. Define the tumor. Once you open the dura, define the borders of the tumor, define the arachnoid, the layers, define where the structures are before you start attacking the origo. Devascularize the tumor, of course, which is a must. Decompress the tumor, deter the tumor, close the dura watertightly, really perfectly, and then dismiss the patient. So this is the management of meningiomas. And in general, we are lately seeing more and more asymptomatic patients. The density of CTs and MR in my country is really very, very high. And the patients are coming with small tumors, asymptomatic tumors. I never ever offer them surgery. I always want to prove the growth, or I want to see some symptomatology. In elderly female, I always ask about hormonal treatment. If they have it by the gynecologist or whatever, take it away, and suddenly the tumor is asymptomatic and not growing. Always consider radiosurgery, which is very, very potential. And don't forget that meningioma surgery has definitive risk. There is no surgery without risk. It's always about anatomy of skull-based system, vascular white matter, whatever. But it's not the anatomy which is stable, like in the textbook or in the hands-on lecture, whatever. This is the distorted anatomy, where which structure will be moved, whether the cell nerve is on the posterior aspect of the tumor or anterior aspect. Will the anterior choroidal artery be moved forward or upwards? These things are important. And this is like anatomical lab which you all should use dealing with the skull base and meningiomas and all the tumors in this region. And you see it's London, Lausanne, myself, the guy from Northern Ireland, India, and just enjoying like little kids dissecting the skull. For some anatomical images, I'm grateful to Pablo Gonzalez Lopez, who is really a rising star on European neurosurgical heaven, and for very good discussions to my very good friend Roy Thomas Daniel from Lausanne, and you see that he really is an enthusiastic neurosurgeon who never ever takes his surgical gloves off. Thank you for your attention.
Shekhar?
So Devpujari sir got disconnected.
Vlad, that was a wonderful presentation. We are just waiting for Dr. Devpujari to enter the scene. And in the meantime, if we have the panelist, Philip, you have any question for our esteemed speaker? Dilip.
No, I think Dr. Benes has given a very good discussion about this very vast and heterogeneous group of tumors that occupy the middle cranial fossa, starting from the sphenoid wing, going all the way back to the Petrus ridge. It's a very heterogeneous group, all with its own peculiarities, which can range from the very simple, small, isolated middle fossa, pure middle fossa-based tumors, to the more complex medial sphenoid wing cavernous sign or the petroclival tumors. So as he emphasized, I think the approach, an understanding of the anatomy and the approach is very, very important, and this would help to approach these tumors in a better way.
Vlad, one thing, you know what you said, that you will not like to go inside the cavernous sinus. You know what? Of course, you will not like to disturb the cranial nerves, and if you are likely to damage the cranial nerves, you will not like to go into the cavernous sinus. But on several instances, the tumors are not that firm, not that solid. You know, they can be soft, and you can actually enter between the cranial nerves and enter into the cavernous sinus. I think this kind of a uniform concept that cavernous sinus forms a border and I will not go beyond this border may not be absolutely acceptable. What do you think about it? What do you have to say?
Atul, I just said that because I knew that you will raise your voice in favor of entering the sinus. Of course, if the tumor is suckable, like pituitary adenoma or some of the meningiomas, then I enter the sinus and do it, certainly. But I really do not chase the tumor when it's from medium soft. You know, then I still have the feeling that some of these tumors do not grow after the extracavernous resection. You have your radiosurgery, so I really enter the cavernous sinus rarely and only for those suckable tumors.
Yeah, Suresh Sankla, yeah, go ahead.
Very nice demonstration of the technique and the method to deal with this difficult problem. Dr. Benes, I just wanted to know, how do you deal with the vascular relationship with the tumor? Encased vessel, particularly the small perforating vessels. How do you deal with them during tumor removal?
Well, it's probably my experience or my experience from AVMs. I treat any vessel like en passage. And even in these tumors, if there is a small tumor, I first treat it as a perforator, and only when it really enters the tumor and I'm sure that it's feeder of the tumor, that then I cut it. And especially in the region along the sinus and in the region of clinoid process where all these important structures are, I'm really very, very as gentle as possible, because it's really one move or one stupid coagulation of a little tiny artery, tearing the little tiny artery from the major artery, which may cause the disaster. So this is exactly the place. One can be a big surgeon with big hands and big movements in the periphery, but then as soon as I get to the middle structures, I really like to have all the bleeding stopped and all the techniques well available. And I can tell you that the case of supra-infra approach I have shown was done with exoscope. And it was really very, very comfortable. And I believe that the exoscope will pull out of our ORs the microscopes, and the optics is a little better than in the microscope. You have one more step for magnification, which you sometimes may need in these tumors.
Sorry, I got lost for a while. There is a question in the question box about if the tumor is adherent to a major artery or the branch of MCA, do you leave some tumor behind, or how aggressively do you dissect?
The older I am, the less aggressive I am. So I freely leave a piece of the tumor behind. There is a dangerous location, which is exactly where the carotid artery enters the intracranial cavity, between the two rings. There the carotid artery is not covered by the arachnoid. And that's exactly the place when you can injure it. And I believe that almost all of us did it. I believe in Anil, you have shown a video a while ago about such a case somewhere, how to avoid complications. So this is the place where I really leave a piece of the tumor behind without any hesitation. And then what's dangerous is the distal branches of the middle cerebral artery, which may be stretched and not well seen at the beginning of surgery. When you still have the main bulk of the tumor, the middle cerebral branches are split. And that's sometimes it's better to leave a piece behind. If you see the arachnoid fold going to the carotid artery on MR, then you can dissect it free. If it's not there, then no one will be able to dissect it.
Vladimir, I have one unrelated question.
Yes, sir.
The world expert on beetles. Have you named a beetle after COVID yet or not?
Anil, of course not, because since COVID started, I'm sitting in at home, you know, and we spend holiday with grandkids just 100 kilometers from here, so no new beetles at all. This is the most important disaster for me, that I cannot travel for beetles. Thanks for asking.
Great talk. Appreciate it.
Anil, what is your attitude towards cavernous sinus involvement of meningioma? What is your attitude? What do you think about it?
I think, in the rare occasion when it's soft and it's coming out, I will chase it. But if it's small, it's firm, I will not go between the cranial nerves. I think when I trained, Shaker was taking all this out, putting a saphenous bypass graft, and the studies showed that was, not warranted. And I think our paper showed that if you radiate residual, the recurrence rate is so low. So I have moved away from aggressive resection in cavernous sinus meningioma.
Atul, there's been a World Congress in Netherlands in 1997, and there was a panel discussion on cavernous sinus meningioma surgery. And there were all the big names sitting there and talking how they are resecting the tumors from the cavernous sinus, and how nice it is because the patients are seeing everything twice, and they have more cars, and they have more wives, whatever you name it. And at the end of the table, Konziolka was sitting. And when they finished with all these big surgeries, Konziolka has shown his radiosurgical series. And in my mind, this was the end of the issue.
Well, shall we move forward to Atul's talk then? Thanks, Vladimir. And we move to Atul's talk, and he's going to take us on a journey. I'm sure he has lots to talk about. So without any further ado, please start, Atul.
So, as rightly said, meningiomas is our life. We live with meningiomas. We live with gliomas. We live with complications. We live with success. We live with beautiful resection, and we live with disastrous complications. This has become our life. This has become our destiny. If we do not learn from our complications, we have not gone ahead. If we do not learn from our experience, we have not gone ahead. I will say that this journey of mine with meningiomas has indeed given me a lot of insight about the subject of neurosurgery, about the philosophy of tumor resection, about the way of tumor resection. As Vladimir said, that I will leave some tumor behind in the cavernous sinus. I will leave some tumor behind in the region of arteries. I may not have done leaving of these tumor behind 20 years ago, but I have learned that I have tried to dissect and I have damaged the artery and I have had a disaster. I had a hemiplegia when I had, this person would have lived completely normally. I have had disasters when I had tried to dissect the tumor around the third nerve, around the sixth nerve, and all those things. Of course, you try to become conservative. You try to become less aggressive. I will say that I will like to be aggressive still, but my aggression will be always towards safety. And this is what our learning is, our learning process is. We learn from our mistakes. We develop our strategy. As regards tumor resection is concerned, you must know, and I will like to show you that I was born in an era where we were doing very extensive exposures, huge exposures, but as you have loved to live with these tumors, you know how to demolish these tumors, how to break into the tumor, how to get into the base of the tumor, how to remove this tumor, dissect from the convexity, and all these things we have learned over the period of several years, over the period of several tumors, over making several mistakes. And what I'm going to show you how I have changed over the period of time in my attitude towards meningiomas in the posterior cranial fossa. Posterior cranial fossa meningiomas are common, like meningiomas elsewhere in the body, in the brain. This is pineal region meningioma, and this is, a difficult meningioma. Great vein of Galen is in question. How to remove this tumor, whether to come below the tentorium, above the tentorium is a question. The question is whether you will be able to remove this tumor is a question. And you have to answer with your experience. Of course, many of these tumors and majority of these tumors can be removed under the tentorium, coming supracerebellar infratentorial. This tumor, you see a little bit up, you have to know where the great vein of Galen is. And if it is below, of course, that is a good indication for coming from up. So there are various kinds of tumors in pineal region. I don't want to really go into my experience with pineal tumor. And tentorial tumors are another very common posterior cranial fossa meningiomas, very common. How to remove these meningiomas is a very regular kind of neurosurgery. How to dissect, how to expose, how to get to the vascularity, how to become safe. Convexity meningiomas are one of the more beautiful and very, very safe tumors to remove. There is no controversy about these kind of tumors. Lateral petrous tumors are very good tumors to remove, and these are very, very safe and standard neurosurgical operation. This is another tentorial meningioma, which is, I will say, one thing I want to say, and one thing I am clear, that in neurosurgery, there is nothing called easy. If I say this is very easy tumor, I will say it is nonsense to say easy. There is nothing easy. But if you make it look easy, if you make it less complex, that is what you are, and that is what you have to do, and that is what you have to learn to achieve. Make it easy. Don't make it complex. and don't make it more complex than what it is actually. So I have generated from this era with Laligam Shekhar when he used to do combined supratentorial, infratentorial approach for pineal region tumor. And this was the paper I wrote with him in the year 1992, 28 years ago, where you know what he was doing? He was cutting the transverse sinus, then going along the tentorium, removing this tumor. And after the removal of the tumor, this was a new technique, this was a new approach, and this is quite a referred technique. And I will say I have developed or generated above this. I will like to go above and below the tentorium. I do not ever do this technique, but I will not say this is the part of my personal development and personal growth that I don't do these tumors in this manner. No matter how vascular it is, no matter where it is going, supracerebellar infratentorial approach is good for these tumors. And I have got a very, very huge experience with pineal region tumors, but that is not the subject of my selection today. So I will like to discuss with you foramen magnum meningiomas, petroclival meningiomas, and my strategy on foramen magnum tumors. Foramen magnum tumor also I have developed. I have gone far beyond what I have learned in the era when far lateral, extreme lateral mobilization of the vertebral artery. Because you know what, Chandranath Sen, Laligam Shekhar, Anil Nanda, we were all together at that time. And these approaches of skull base were being developed at that time. And I remember staying in Anil Nanda's house, and I did a dissection of extreme lateral approach in his lab, and that dissection was to be shown in one of the meetings. And we were very familiar with this mobilization of vertebral artery and the condyle and lateral masses of atlas and axis. So we were born in this era. At least I was born in this era when very heavy approaches, vertebral artery manipulation, condylar resection, anatomy is the key to any success of any region. Foramen magnum is no less than any other region. How to get to the vertebral artery? What are the triangles here? What are the muscles here? What are the muscles behind? What are the muscles in front? How to get to the vertebral artery and how to mobilize transoral surgery for. Believe me, at that time when I was actually doing skull-based surgery with Alan Crockett before. Alan Crockett also developed a very fantastic approach, transoral approach to foramen magnum meningiomas. Unbelievable approach today, but that is the journey that we traversed along. And transoral dissection and removal of meningioma was also an issue. Cranial nerves are there, lower cranial. Foramen magnum is a smallish territory. It is quite compactly located with various critical neural and vascular structures. You have to learn how to able to handle these, how to resect, how to dissect between the nerves, between the vessels, and that is how you develop into neurosurgery. So my meningioma surgery in 1988, 32 years ago, with extreme lateral exposure, transcondylar. So 1988, we were doing all these kind of things. But as we developed, as we learned, art of breaking the tumor, opening smallish areas, dissecting between the nerves, dissecting between the vessels, getting and developing an exposure, I will say I have never actually needed such an approach. I will not condemn at all, because this was the generation of personal growth and personal birth of mine. And you can see, when I will show you this picture again, I was born in an era where I was myself involved with various techniques, where extensive exposures of the petrous bone, mobilization of the facial nerve, mobilization of the carotid artery, mobilization of the cavernous sinus, and remarkable removal of petrous bone to approach these tumors. And this was the cover page of my own book, where I showed this kind of dissection. In my book, there is another smallish approach which I labeled it for the first time, very small keyhole approach, supracondylar infrajugular bulb keyhole approach to anterior medullary lesions. So this was the approach I described. Subsequently, somebody else also from Japan had described this approach to expose vertebral artery and pica aneurysms, but this was the approach that we described in the year 1992, so 28 years ago. And even I wrote this article on transoral approach to removal of intradural lesions at the craniocervical junction in the year 1992, where I said that this is not required. Crockett and Sen had introduced this series, and if you read this beautiful article, I will say this article demolished transoral approach for intradural tumors at that time. Of course, there is a resurgence with endoscope and all those things, but I don't believe all those things. And this article, this letter of mine is highly cited letter, and I will say one of my very important letters in neurosurgery, where I wrote that transoral approach is not a very good approach. So what we did was this article of mine written in the year 2001, but after a lot of experience from 1992 onwards, where I said that anterior foramen magnum meningiomas can be removed by posterior suboccipital approach. So I had written about 17 cases in the year 2001, 20 years ago, that you can do midline exposure and you can remove these tumors. Of course, understanding of tumors was not so great at that time. These neurinomas were also removed by quite, of course, this is clearly a neurinoma, but they were not well diagnosed at that time. And I have written about neurinomas, about interdural approach, and how you can, in the year 2008, I wrote that neurinomas are of 3 types. A, B, and C. A is intradural, I had said at that time. B is interdural, C is intradural. So I had written 60 cases in the year 2008. Then this tumor, I had thought that this is intradural, and these are interdural. Working within the dura was the answer to the question. Then I wrote subsequently about additional 50 cases where I identified that all these 3 components are interdural. There is no need for extreme lateral or far lateral. There is no need to open the bone. Directly go to the tumor, directly open the dura. You see, this is the tumor. You can see the tumor. I don't want to show too many videos because they might consume time, but many of these tumors I remove in exactly 10 minutes. You see, this is the tumor. This is the large tumor. There is no opening of the bone, no opening of any spinal structure. Open the dura and then work within the dura. And believe me, many of these tumors which were taken hours and hours earlier, of course, I don't want to go negative on any of these things, but some of these tumors can be removed in exactly 10 minutes or maybe less. I don't want to say too much about this, but if you have the art of working within the dura, you can remove these tumors. And this was a big tumor actually. And then you see these foramen magnum tumors, these are lower cranial nerve tumors. And these tumors, and I recently wrote one article on this subject. I hope I can show you that article, that these tumors are also within the dura. And working within the dura, you can have a very fantastic, and the exposure can be limited. Of course, for this, you have to do mastoidectomy. You have to come infralabyrinthine. You have to open the skull base, and you have to have a wide exposure. Then work within the dura, and you can 100% of time, you should aim at recovery of the lower cranial nerve function, which has never been actually written about. So this is my paper, which is going to be published, Interdural Surgical Strategy for Lower Cranial Nerve Tumors, Lower Cranial Nerve Schwannomas. I had written recent experience with 14 cases. This is another case. If you realize that the whole tumor is within a confinement, it is a lockdown. These tumors are locked within the dura, and working within the dura, you can remove these tumors in a very beautiful manner, and you can aim to have a recovery in the lower cranial function, a event which has not really been discussed. Here, this is a picture. I'm not sure if I can show you the video, but there is a dural boundary, and you can work within the dura, and you have to remove this tumor. So radical massive exposures is not necessary. There is a big cisterna magna here. You retract the cerebellum and you get a huge exposure. And then you have to work within the dural confines. And if you know how to handle the tumor, how to dissect between the cranial nerves, how to expose and separate the blood vessels, you can do a beautiful resection. In the foramen magnum, I had written one article long time ago on, this was article published in the year 2005, where I had written about 7 cases of endodermal cyst. This was the largest series at that time of endodermal cyst in the region of foramen magnum. Now I have a series of more than 33 or 34 cases, which is also the largest in the world. And we said that if you realize that this is not a meningioma and this is an endodermal cyst, believe me, this tumor surgery can be an absolute. You don't need to expose widely. You don't need to expose huge, and you can have a very fantastic resection. Working within the dura, open the cyst, this whole thing will come out like pus from the abscess, and then you have to remove the wall of the abscess as much as it is safe sometime, and you have some soft calcification within the tumor. You see, this is the soft calcification. How is a decision that you have to verify all the tumors. Sometimes they can go across the middle, very massive exposure. You should know the tumor. You should learn to know the tumor, learn to understand these tumors, and you will realize that many of these tumors do not need very wide exposure. If you read the articles in the year from 1990 to 2000, you will find several articles in the literature, this retroodontoid pseudotumor being removed by extreme lateral approach, far lateral approach, by mobilization of the vertebral artery. We introduce a very beautiful concept that this retroodontoid pseudotumor is a result of a atlantoaxial instability, and you need to stabilize, and this retroodontoid tumor will disappear on its own. So this was a remarkable contribution of mine, which was published in the year 2006 and then 2004. And then, of course, there are several other publications saying that retroodontoid tumor may not be removed. So then we reported about retroodontoid pannus. Even if you realize transoral surgery was born to remove this pannus, because this pannus was considered to be a pathological phenomenon. We introduced the concept that distraction reduction of joint can relieve the pannus in the immediate postoperative phase. So transoral surgery, extreme lateral exposures, and believe me, my dear friends, all these, if you see the literature, there are several replete. The literature has several articles where transoral surgery, extreme lateral, far lateral have been done for this. I have no doubt, and you please don't keep any doubt, that this article completely revolutionized the treatment. And if you have any article written after 2008 on transoral surgery for this, show me. I will be very, very happy to see, because nothing is written. Retroodontoid cyst. If you see the articles from 1990 to 2010, you will find several articles in the literature mentioning extreme lateral, far lateral approach to remove this cyst, puncture the cyst, this, that. But you see, this cyst is a manifestation of atlantoaxial instability. You stabilize the joint, the cyst will disappear on its own self. There is another case, there is a retroodontoid cyst with ossodontoidium. You stabilize the joint, the cyst finishes on its own. So there is no need for, basically what I'm trying to dwell upon is that there is a possibility of avoiding these kind of extreme approaches if you know what is the tumor. And I'm coming to meningioma. If you know what is the meningioma, if you know what is the consistency of the meningioma, You don't have to start with a huge exposure when the meningioma is a soft meningioma. You don't have to, I have realized that you come to the meningioma quickly. This was my article in the year 2001. And now we have one of the world, not one, largest series in the world on foramen magnum meningiomas. And I have never done any lateral or far lateral or extreme lateral. Midline, you see, this is my exposure. Elevate the cerebellum, work within the cranial nerves, and you can do tumor resection on a very, very regular basis. So I have got several cases, whether the artery is encased, whether the artery is not encased, whether the tumor is soft, whether the tumor is lateral. You see, this is lateral. Now for this lateral, if you start having a very huge exposure, I will say it is not necessary. But I have learned the hard way. You must remember, I have worked on several meningiomas all during my life in a very heavy surgical department. And this is the tumor encasing the vertebral artery. How to dissect, how to get the exposure, how to work within the arteries. If you say, I have damaged the pica, I have damaged the perforator, then it's absolutely wrong. If you can do it safely, if you can do it beautifully, that is the way neurosurgery has to be done. And I will say, beautiful, the most quickly, beautiful resection. These are easy. I will not again say any tumor is easy in neurosurgery, but even the meningiomas, I'm showing you only few meningiomas here, but I have got the largest experience in the world on these meningiomas, anterior, this meningioma, all kinds of meningioma, and total beautiful resection, complete both vertebral arteries, only midline exposure. Come into this area, work within the tumor, no need for any kind of exposure, additional exposure, have the vertebral artery exposure over the arch of atlas if necessary. Otherwise, all my tumors have been removed by elevation of the cerebellum, working within the cranial nerves, dissecting, demolishing the tumor, learn the art of breaking the tumor, and you can remove this tumor. And I will show you some very, very dangerous and difficult tumor. You see this tumor, this is located lateral. That is one thing, is no problem. Vertebral artery completely encased, no, not much of a problem. But you see this tumor on CT scan is completely bone. It is a solid bone, ossified bone. I did this tumor 10 years ago. Complete bone. Bone means solid and arteries encased. So both these combination makes this tumor a very difficult tumor. And this tumor was removed 10 years ago, you see, by this limited exposure, no extreme, nothing. And you see the vertebral artery, complete removal of this tumor. Now you see this another horrendous tumor. You see this CT scan showing a calcification, completely rock. And you see the plain CT bone window showing complete rock. And if you realize both the vertebral arteries completely encased within a rock. So this tumor is, I will say, one of the most dramatic, dangerous tumor I removed several years ago. And this tumor is completely removed. And I will show you the outcome of these tumors very soon. So this is the exposure for any kind of tumor, whether it is rock or whether it is liquid, whether it is fluid. This is the exposure. And this is good enough for me. Condylar resection, vertebral artery mobilization. Expose the vertebral artery here if it is necessary for you. This is another horrendous tumor. You see complete bone. You will not even see the brainstem where it is disappeared on the CT scan. Then MRI, of course, shows you. Then you see both the vertebral arteries encased within the tumor. You see here vertebral arteries within a calcified rock. You have to drill or you have to break the bone and then save the artery, save the nerve. And this is the post-operative. And this, you see this paper I published in Ossified Anterior Foramen Magnum Tumors, long-term outcome. And believe me, I have outcome more than 10 years surgery, and all the patients have come no recurrence and complete normal life. So even in this situation, ossified or whatever, you can give new life to this patient. You cannot say no to these people because there is a possibility of giving beautiful new life. I don't want to go into too much videos, but let me show you some by this kind of minimal exposure. what I'm trying to do, learn the art of breaking within the cranial nerves. And I will say that no, never. I'm not saying sometimes, I'm saying never. I have needed, and I'm talking on the basis of the world's largest experience, that never I had need for doing extra exposure other than what I am showing. So I'm also not trying to say